Talk will be delivered by Dr. Ashok, he is MD and he is Senior Interventional Cardiologist, Patna. So may I request Dr. Ashok to proceed.
Good evening, respected chairperson, and especially Dr. Alok, who has invited me for the talk, HFPEF in 2024. This is one of the most neglected topic, but after 2021, the Imperial Reserve trial, interest has increased in this management and diagnosis as well. So, as we all know that heart failure is clinical diagnosis, so we have to look for the history, sign and symptom of the heart failure, along with if the patient is having symptom and sign of heart failure, either due to structural or functional abnormalities in heart, and having elevated natriuretic peptide level, and with objective evidence of cardiogenic, pulmonary or systemic congestion, we can diagnose a case of heart failure. But according to the ejection fraction, it has been subclassified, and if patient is having sign and symptom of heart failure along with normal or near normal ejection fraction, that means more than 50%, the diagnosis will be labeled as HFPEF, heart failure with preserved ejection fraction. There are certain phenotypic classification of HFPEF. So it's based upon the clinical presentation. Many a time you will see the volume overloaded cases present with the sign and symptom of congestion. Sometimes patients only present having elevated LV feeling only on exercise, and sometimes you will see only problem in right side of the heart. Based upon the etiology, it has been subdivided like predominant metabolic HFpEF, that is garden variety, and sometimes it is associated with CAD, right side predominantly, associated with atrial fibrillation, hypertrophic cardiomyopathy, valvular or high output states. Sometimes rare causes that has been subclassified as zebra. So coming to our part, as we have learned in our medical school days, that the incidence of HFpEF is very high, up to 50% in Western world. But that is not true in our part. Trivandrum Heart Registry has shown the prevalence of HFpEF is only 26%. That means 1 in 4 heart failure patient is having HFpEF, and it is more common in women compared to men. But different registry of Indian registry has shown the different prevalence, and most of the registry agreed that in India the men are more commonly involved with HFpEF, and the prevalence increases with different study ranging from 26 to even up to 100% with Indian clinical observational study. So Indian heart failure patient phenotype is different compared to other. And overall mortality is, of course, overall mortality of HFpEF is lesser than compared to HFrEF, whereas after readmission, the mortality is equal to HFrEF. So when try to prevent the heart failure hospitalization with HFpEF patients, otherwise its mortality will match with the HFrEF. And HFrEF patients on guideline directed medical therapy, its prognosis is even better compared to HFpEF. And this is the difference between HFpEF, heart failure with mildly reduced EF. So HFpEF is occurs in elderly, obese, female, and mainly associated with 2 to 3 comorbidities. And most common comorbidities in Indian part is hypertension, whereas CKD, atrial fibrillations are mostly involved with HFpEF subgroup of patients. So coming to the pathophysiology, it occurs due to diastolic dysfunction, either due to impaired relaxation or increased passive stiffness of heart. Even sometimes chronotropic incompetence present, like this problem of HFpEF. And the earliest thing is to increase in pulmonary arterial pressures that occur usually with exercise. So many a time you will see sign and symptom of heart failure without any diastolic dysfunction and with raised pulmonary pressure. So lots of comorbidities associated with HFpEF, and hypertension is the commonest one. Many common heart failure signs and symptoms are present only in patients with advanced HFpEF. But in early HFpEF, often patients present only with exertional symptoms. So these non-specific and widely prevalent symptoms, especially in the elderly population, can make it difficult to differentiate HFpEF from the other non-cardiac causes of dyspnea on exertion. And this staging system is also applicable with HFpEF, not only with the HFrEF. So stage A, B, C, D is applicable. And these are the common signs and symptoms applicable in both with HFrEF, HFpEF. So breathlessness, orthopnea, PND, likewise. Elevated JVP, I am not going to detail in these. And these are the common method how we approach to any heart failure patient. So ECG is must, then we do echocardiography, X-ray, natriuretic peptides level, and common comorbidity screening by CBC, KFT doing, and thyroid, iron, yeah. So in some patients, the diagnosis of HFpEF may be clear. When the HFpEF diagnosis is not clear, further assessment are crucial. In such cases, we need some scoring system or algorithm. So challenges in diagnosis of HFpEF. So how to approach a patient with HFpEF or having sign and symptom of heart failure with normal or near normal ejection fraction. So these are the certain criteria. If the patient is having sign and symptom with normal ejection fraction and having dilated LA, that means more than 34 ml per square meter with elevated natriuretic peptide. Having elevated pulmonary systolic pressure, we can label it as a case of HFpEF. And this is some important point. So, difference between diastolic dysfunction, diastolic heart failure and HFpEF. Diastolic dysfunction is not a prerequisite for diagnosis of HFpEF. You can diagnose HFpEF even without having diastolic dysfunction. And it does not require always invasive hemodynamic testing. Abnormal BNP does not exclude the diagnosis of HFpEF, because you will see in obese patients your natriuretic peptide level doesn't go up very high. So elevated pulmonary artery systolic pressure is very important. There is no standardized protocol, and systemic evaluation of the patients with HFpEF or when heart failure with mildly reduced ejection fraction, CAD is very important, because the association of CAD is very high, and many a time revascularization improves the symptom. So these are the two scoring system, H2F, PEF score. And this is mainly relies upon comorbidities. So there are certain scoring system for if the patient is obese or overweight, more than BMI 30, given 0.2, if patients given 0.3, and if patient is having hypertension, and not only hypertension, that has to be taken more than 2 antihypertensive medicines, only then it has been included in this scoring system. So if the score is more than 5, HFpEF is clear. And if the diagnosis is not clear with this scoring, we can use heart failure association PEFF score, and it mainly relies upon the biochemical and echocardiographic parameter. So ruling out cardiac and non-cardiac comorbidities condition that may mimic heart failure. In echocardiography, there are major points and minor criteria. A major criteria is to measure the septal E prime if it is less than 7 centimeter per second, or the E upon E prime is more than 15, or the tear velocity is more than 2.8. That means the patient is having increased systolic pulmonary systolic pressure. So it has been given 2 points. Morphological echocardiographic parameter, that is LA size, and LA volume index is more than 34 ml per square meter. Whereas mass index is more than 149 for male and 122 gram per square meter for female. Whereas if the patient is in sinus rhythm, NT-proBNP level of more than 220, and if patient is in AF, the level cutoff is more than 660. And if the including all these points, if it is more than 6, so diagnosis of HFpEF is clear. And this is simplified version of all these criteria, and it has been proposed by Heart Failure Association of India. So to simplify, sign and symptom plus ejection fraction more than 50% with structural or functional abnormalities of heart failure and having increased NT-proBNP, we can safely label it as HFpEF. Now coming to the management, primary care management, because most of the patients usually treated by GPs first. So primary care in HFpEF treatment, and there are certain barriers to optimal care of HFpEF patients. First and foremost is the diagnostic difficulty to challenge the normal echo and unclear illness perception and management disparity, because up till 2021 we don't have any class 1 indication or even approved therapy for this entity. Now coming to the management proper. So lifestyle modification is first and foremost thing. So reduce the consumption of sodium, but extreme reduction of sodium is many a time counterproductive, particularly in HFpEF patients. So reduce the dose to 2 to 3 gram, but not below that. Regular aerobic exercise is recommended. Restrict calorie, and weight management is very important. Most of the patients is obese, having diabetes or hypertension, so look for obstructive sleep apnea, and by using CPAP you will see drastic improvement in symptom of a HFpEF, and BP monitoring and control of the BP, because hypertension is the most common associated comorbidities with this. So what are the goals? Our main goal is to reduce the heart failure symptom, increased functional status, and reduce the risk of hospital admission. So preferred therapy for symptomatic patient is a diuretic. So we have to manage the volume overload. For that, diuretic is class 1 recommendation. And now SGLT2 inhibitor has come in major way in the treatment of heart failure with preserved ejection fraction. Even in prevention and even in the treatment arm, we can give this SGLT2 inhibitor. Then add mineralocorticoid receptor agonist. Yeah, these are the certain trials that has proven the efficacy, like Emperor Preserve and Deliver. Both have established the role of empagliflozin and dapagliflozin in terms of reducing heart failure hospitalization as well as cardiac death, but it has not much effect in overall mortality. Whereas you will see the Ernie has missed the bus with very narrow margin, as p-value is 0.06. But sub-analysis of this Paragon HF trial has shown its beneficial effect when the EF is below 57%. And that's why this is the statement of Braunwald, that heart failure with preserved ejection fraction, a stepchild no more. It would appear that finally the dam has been broken and that HFpEF is no longer a stepchild. So these are the effect how SGLT2 inhibitor works in patients with of HFpEF. It reduces the preload, it has beneficial effect in myocardium, and reduces afterload as well. So ultimately improve cardiac structure and function. These are the 2022 AHA guideline. Diuretic is only the class 1 recommendation. Apart from that, SGLT2 inhibitor has got 2A recommendation, whereas Ernie, MRA and ARB has got 2B recommendations. And FDA has given approval for Ernie in elderly chronic heart failure patient irrespective of ejection fraction, so we can give. And you will see the definite benefit, beneficial role of SGLT2 regardless of the ejection fraction, whereas definite declining benefit at higher EF. So higher the EF, the role of Ernie is lesser. So after EF 57, there is no much effect of Ernie in treatment of HFpEF. These are the recommendation of 2022. Yeah, these are the other therapies. So rhythm control is better in HFpEF patients because it causes improvement in symptom. There are one trial, that is champion trial, that has shown the monitoring of pulmonary arterial pressure, because on exercise earliest increase in pulmonary arterial pressure, and that can be monitored with device CardioMEMS, and FDA has approved this device as it has reduced the more than 50% reduction in failure hospitalization. Another device is interarterial shunt of 8 mm device that make a hole in interarterial septum, and it decongest the left arterial pressure. That's why it shows some clinical benefits. And this is an important slide when to refer the patients to a specialist. And the mnemonics is I need help. I stands for intravenous inotropes and worsening in NYHA class, worsening in EF, patient need defibrillator shock and hospitalization. So to conclude, control and symptom of congestion is very important, and start SGLT2 inhibitor, start early, follow up within 2 weeks, and refer to cardiologist if I need help mnemonics quantify the criteria. Okay, thank you.